options and efforts to test them in the private sector. This second hearing focuses on more incremental private sector-driven approaches to reforming payments. We will hear shortly from private payers, a physician organization, and a practicing physician who are engaged in efforts that reward physicians who provide high quality and efficient care to patients. Dr. Bender is recognized for 5 minutes.
Thank you, Chairman Herger and distinguished members of the Subcommittee on Health. I'm Dr. John Bender. I'm a family physician in Fort Collins, Colorado, and I'm CEO of Miramont Family Medicine, which is a network of patient-centered medical homes. Now, in 2002, my wife Teresa and I moved back to Larimer County, where we're from, and we purchased one of the oldest practices in Fort Collins, Colorado. They'd been there for over 40 years, and were basically doing things the same as they had in the 1970s. They left me one computer and one employee. That was 10 years ago. Today, we have over 50 employees, 14 providers, including 8 physicians. We have over 80 computers in a centralized data center serving 4 different parts of our state, and we have about 27,000 patients. Now, during the same period of time in Larimer County, 34 primary care physicians closed their doors or stopped providing primary care services. 8 of these were actual bankruptcies. And yet at the same time, we saw a doubling in the number of emergency room beds and an increase by the number of emergency room physicians by 50%, suggesting that if patients didn't have a patient-centered medical home like myself, they were going to the emergency room at a later stage of their illness for a higher cost, increasing healthcare premiums for everyone across the state. Now, how is it that Miramont was able to double in size, grow at 34% per year to the size that we achieved in this economy, while other family physicians were saying, I give up and walking away? Well, part of it was in 2007, we made the conscious decision that we were no longer going to just focus on volume. We were going to make sure that we had a high-quality product that was safe and efficient, and we believed that if we built the best product in the marketplace, the consumers would vote with their feet and we would be able to maintain our solvency. Because after all, I didn't want to be the 35th practice to close or the 9th physician to bankrupt. And so we pursued NCQA, Patient-Centered Medical Home Recognition. That's the National Committee of Quality Assurance. We achieved level 3, which is the highest level of patient-centered medical home. It basically meant that we, after a 6-month audit period, were able to show improvements in our workflow and the way we retooled things so that we could deliver team-approached care. We also had, for example, a patient portal where patients could go online, look up their labs, see their clinic record. They could send me a HIPAA-compliant email, or they could schedule appointments. And we also conducted care coordination through the transitions of care as people went from hospitals to nursing homes, etc. Our next big break came in 2008 with the multi-payer patient-centered medical home pilot. This was the brainchild of Dr. Paul Grundy and others at IBM, who had compelled the top payers in the United States, WellPoint, United Health Group, Cigna, Aetna, and Humana, to test the patient-centered medical home model. It was based on some of the beliefs and work that Dr. Barbara Starfield had published 10 years earlier, suggesting that if we put an emphasis on primary care, we could bend the health cost curve. And so 17 pilots were selected. Miramont was one of them. It was convened under a group called the Health Team Works, and it was basically an alliance of payers, including insurers, employers, and physicians. We agreed on the quality metrics that we were going to track to show improvement on, and we also agreed on a 3-tiered payment system based on fee-for-service, per member per month fees, and pay for performance. Now, fee-for-service was included, and I'll tell you why. There was an understanding that volumes in primary care were actually too low, and if we were going to pull people out of emergency room and urgent care and other high-cost centers, we would have to incentivize primary care physicians in order to help them to build the capacity to see the increased volumes. Per member per month fees ensured that I was able to provide what was otherwise non-revenue generating activities, such as having a diabetic nurse educator in-house or a psychologist and doing care coordination. And then finally, pay for performance bonuses made certain that we just didn't report our metrics to a centralized data registry, but we were actually working to try to reach certain target goals to help improve our delivery of evidence-based medicine. The results are in and they're fabulous. United Health Group has told us that Miramont reduced hospital readmission rates by 83% compared with our peers. A year ago, the state Medicaid program joined the pilot, and they said that we have an ER utilization rate that is a negative 219% compared with our peers. And so I call on the Subcommittee on Health of the Ways and Means Committee of the House of Representatives to compel the Department of Health and Human Services to immediately deploy the patient-centered medical home payment standard nationally in order to conserve the strength of the primary care workforce, in order to increase the quality of health care delivered to entitlement benefit or beneficiaries, and to also reverse the escalating costs that are burdening the American taxpayer by using a payment method, a payment standard that has been proven and is now being adopted in the private sector. Thank you.
Thank you.